This is Dr. Lilian Andrade. I'm board certified in family medicine and geriatrics, and today's topic is delirium. So let's get started. Delirium is an acute fluctuating disturbance in attention, awareness, and cognition. It is often triggered by an underlying medical condition, medication, or environmental change. It is crucial to distinguish delirium from dementia. While both involve cognitive impairment, delirium has a rapid onset, fluctuates throughout the day, and is typically reversible if the underlying cause is treated. Dementia, on the other hand, develops gradually and is usually irreversible. Key differences include onset, delirium is sudden while dementia is gradual, course, delirium fluctuates while dementia is typically stable day to day, consciousness is often impaired in delirium and usually clear in dementia, and attention is markedly impaired in delirium and intact until late stages in dementia. Delirium can present in different forms, which can sometimes make diagnosis challenging. There are three main types of delirium. Number one is hyperactive delirium, characterized by agitation, restlessness, and hallucinations. Patients may become combative and have heightened awareness. Number two is hypoactive delirium. Often underrecognized, these patients appear drowsy, lethargic, and withdrawn. It is more common in older adults and is associated with worse outcomes. Number three is mixed delirium. This is the most common form where patients fluctuate between hyperactive and hypoactive states throughout the day. Hypoactive delirium is particularly easy to miss, so maintaining a high index of suspicion is crucial. Delirium is incredibly common in hospitalized older adults, particularly those in intensive care units, post-surgical patients, or those with underlying cognitive impairment. The studies estimate that up to 50% of older adults in the hospital experience delirium. In ICU, patients' rates can exceed 80%. Delirium is linked to longer hospital stay, higher mortality rates, and increased risk of long-term cognitive decline. Delirium often results from multiple factors. A useful mnemonic is I watch death. I from infections including UTIs and pneumonia, W from withdrawal including alcohol and benzodiazepines, A from acute metabolic disturbances, T from toxins including medications like benzodiazepines and opioids, C from CNS pathology like a stroke and tumors, H from hypoxia, D from deficiencies including vitamin B12 and thiamine deficiency, E from endocrine disorders, A from acute vascular events, T from trauma, and H from heavy metals. Older adults, especially those with baseline cognitive impairment, sensory deficits, or immobility, are particularly vulnerable. The gold standard for diagnosing delirium is the confusion assessment method, the CAM, which requires 1. Acute onset and fluctuating course, 2. Inattention, 3. Disorganized thinking, or altered level of consciousness. Both criteria 1 and 2, plus either 3 or 4, must be present for diagnosis. The 4AT is another quick and effective bedside screening tool for delirium that doesn't require specialized training. It assesses 4 key areas. Number 1, alertness. Is the patient drowsy or agitated? Number 2, AMT, abbreviated mental test for. Ask the patient their age, date of birth, location, and current year. Number 3 is attention. Ask the patient to list the month of the year backward. And number 4, acute change or fluctuating course. Ask caregivers if there's been a recent change in mental status. A score of 4 or more suggests possible delirium, while 1 to 3 indicates possible cognitive impairment requiring further assessment. Prevention is key, particularly in high-risk patients. Evidence-based strategies include ensuring adequate hydration and nutrition, promoting early mobilization, providing orientation cues like clocks and calendars, optimizing sleep by minimizing nighttime disturbances, addressing sensory impairment with hearing aids and glasses, and avoiding or minimizing delirium-induced medications. Studies show these non-pharmacological interventions can reduce delirium incidence by up to 40%. Effective delirium management involves 3 key steps. Number 1, identify and treat underlying causes by correcting electrolyte imbalances, treating infections, and discontinuing offending medications. Number 2 is supportive care, ensuring hydration, nutrition, and early mobilization. Number 3 is environmental strategies like reorienting the patient, providing familiar objects, and involve family members in their patient care. Medications like antipsychotics should be reserved for severe agitation or distress that poses a risk to the patient or caregivers. Use the lowest effective dose for the shortest duration possible. And remember, never, never, never use benzodiazepines to treat delirium. Delirium is a medical emergency that requires prompt recognition and intervention. By understanding its risk factors, using tools like the CAM and the 4AT for diagnosis, and emphasizing prevention strategies, we can improve outcomes for our older adult patients. If you found this video helpful, please like it, share it, and subscribe, and stay tuned for more geriatric education content.